Hello and welcome to the stakeholder webinar for the Healthier at Home pilot program. My name is Juliette Mullen with Manatt Health, and we are supporting the California Department of Aging in the design and launch of this program. I'm going to walk us through some logistics for this session today before we begin. Let's go to the next slide, please. Thank you. Specifically, I want to take a moment to share with you all how you can participate throughout today's session. Throughout the session, CDA will take public comments at designated times during which anyone participating today is welcome to provide a verbal comment or a verbal question. The way that will work is you will be invited and prompted to use the raise hand feature in Zoom. You can see it down on the bottom of your screen, and there's also a visual of it here on the slide. If you've joined us by phone today, you can press *9 on your phone's dial pad to enter the line for a verbal comment or question. When the time comes to take verbal questions and comments, the facilitator will call on people in the order of the line. They will say your name, and the facilitators will allow you to unmute yourself and invite you to ask your question. Throughout the session, we also encourage everyone who's joined us today to provide written comments, questions, etc., through either the Q&A feature or the chat today. We do have an open chat, and folks are invited to participate and share their questions, thoughts, feedback, reactions to today's conversation in the chat, which will be open to anyone. If at any point you have a specific question for the panelists only, or if you have any technical issues, we invite you to use the Q&A, which will be visible. Your question will be visible to the panelists, and they'll be able to triage your question there in the Q&A. Throughout the webinar, the CDA communications team will be in the background answering any Zoom technical questions. If you experience technical difficulties during this session, as I noted, please drop that in the Q&A and someone will help you in the Q&A. During today's event, live closed captioning will be available by clicking on the CC feature at the bottom of your screen. And with that, I would like to introduce Sarah Steenhausen, the Deputy Director of Policy Research and Equity for the California Department of Aging. Sarah?
Great. Well, thank you so much, Juliette. It's wonderful to be here and appreciate you all logging in to learn more about the Healthier at Home program and our proposed design. As you know, I'm Sarah Steenhausen with the Department of Aging, and we are also joined by Tanya Bautista, our Chief of Policy with the California Department of Aging, as well as you know, Juliette Mullen, who just introduced herself with Manatt Health Strategies. And I just want to say that CDA has greatly appreciated the support of Manatt that they've provided in this early kind of development phase of the Healthier at Home program. So next slide, please. So just a high-level overview of our agenda. We've done our welcome and background. I'm going to now walk through the overview of the Healthier at Home pilot program, kind of the background and context for it, some of the design elements, and our next steps, and then we will walk through the timeline. And most importantly, we want to have time for question and discussion. So we might even wrap up the presentation before 10:40, which would leave us a little more time for question and discussion. Next slide. So as background, next slide. I want to set this in the context of our state's master plan for aging, which, as you may be aware, the master plan for aging is the state's effort to prepare California for its growing and increasingly diverse population of older adults, people with disabilities, and family caregivers, so that we can be prepared for the demographics by 2030, when 1 in 4 people will be over age 60. The purpose of this program really aligns with our Goal 1 strategy, which is focuses broadly speaking on housing for all ages and stages. Next slide, please. So I wanted to just give you a high-level overview of the Healthier at Home program. It was authorized and enacted as part of the state budget, providing $12.5 million through June of 2026 to launch a pilot program. The pilot program would provide a nurse and a community health worker in senior housing sites in 8 counties of California: Contra Costa, Fresno, Orange, Riverside, Sacramento, San Diego, Shasta, and Sonoma. Together, the nurse and community health worker would provide the residents with health education, navigation, coaching services, and support to meet their daily living needs. The focus of this pilot, more broadly speaking, is to help older adults remain at their home and avoid institutionalization. So again, meeting this broader goal of housing for all ages and stages and keeping people in the setting of their choice. Next slide, please. So I think what's important to note about the pilot counties, this was authorized, as I said, by the legislature, and they did identify the counties that they wanted to pilot in. What's wonderful is that there's kind of a range of both more rural counties and more urban counties, as you can see in this graphic. So they really reflect a diverse range of demographics related to population density and resident age and income. Next slide. So just again, the basic framework of this program, CDA, and we will walk through the specifics that we're proposing for this. CDA intends to award one or more grantees to pilot the model in the 8 counties. And we'll explain what we mean by that when we talk about one or more grantees. The grantees will pilot the model in senior affordable housing developments over a 2-year project period. CDA, working with our academic partners, will evaluate the pilot and publish a report to the legislature and the public that evaluates the efficacy of the program. Next slide, please. I wanted to provide you a bit of the background on the design principles that we've used in our work with Manat in developing this program. We really thought it was important to leverage some of the existing evidence-based models that have shown similar models to be effective in different parts of the country. We really want to target this and embed equity for addressing the needs of older adults from under-resourced communities who might not have access to the services that they need in their senior housing communities. And then finally, we want an evaluation that really will inform our future pathways for funding. What we really want to avoid is a situation where we have a pilot that's one and done and okay, well, that was nice, let's move on. We really are hoping that our learnings from this can be leveraged and either incorporated into existing programs or launched as their own effort, depending on the funding availability. Next slide, please. So in terms of our design process, the way that we embarked on this effort was we've conducted research, desktop research. We've conducted a number of interviews with people that have administered similar type programs, and we've had smaller focus groups to inform the design of this pilot program. So all of that work has really helped us present what we have produced today. And again, what we're proposing to you today is not set in stone. We are still seeking input, which is the purpose of this webinar. And we encourage your questions and comments throughout to help inform our thinking of this program. Next slide, please. So I wanted to elevate, as I noted, we really are trying to leverage our learnings from existing promising programs that are out there, that starting in 2009 with the Capable program, through the launch of Vermont's SASH program in 2011. In California, a program called Life Steps, which provided nurse coaching pilot program to low-income seniors with on-site nursing services in California. And then in 2017, the I Wish demonstration at the federal level through the Federal Department of Housing and Urban Development. We don't have the time to go through the specifics of each of these models, but the really important point of this is that we have learned from each of these models in their various successes in addressing residents' needs, helping them access services that they need in the community, and hopefully many of which have proven to reduce the overall cost of care by connecting people with the services they need. Next slide, please. So now we are going to walk through our proposed model. Next slide. So based on the research that we've done and the interviews that we've conducted, we are proposing, there are a few elements that were already structured as part of the legislature's budget investment that was signed by the governor, which was to have a nurse and a community health worker at the pilot sites that would assist the residents in accessing the services they need and providing coaching and other services. But we have kind of built out this model a little further, and we'll walk through how we anticipate the Healthier at Home team providing these services, and then how they connect not only with the senior affordable housing staff, but also the community partners. Next slide, please. So more specifically, we anticipate that the Healthier at Home services would include a range ranging from education on chronic conditions, medication management, health system navigation, and support in transitions from settings from hospital to home or from nursing home back to home, caregiver support and education, as well as connections to building activities and social opportunities. And then finally, referrals for social services, potentially to CalAIM Enhanced Community, and ECM and community supports, as well as other services. Generally speaking, the nurse would be responsible for providing the assessments and identifying the needs of the resident. And then the community health worker would work with the residents on providing education, health system navigation, caregiver support, and other referrals to community services and supports. Next slide, please. So what we anticipate is, based on this, what we hope is that this strategy and approach would help improve the residents' quality of life. It would help enhance access to healthcare and social services, and ultimately reduce the cost of care and reduce caregiver burden. We're going to walk through a little more of the details in terms of, how the structure of the program and the framework for the staffing of these models, but this is the very high level overview and what we anticipate the outcomes would be based on the design of the program. Next slide, please. So now I'm going to dive into a little more of those details about the proposed pilot. Next slide. So the way that we're going to work it is that the Department of Aging would work with the grantees across the senior affordable housing sites for the 8 pilot counties over a 2-year period. And now I think it's my opportunity to transition to Juliet Mullen, who's going to provide a little more of the details about how we propose the pilot would be administered.
Wonderful, Sarah. Happy to take a few of these slides here. Thank you. So as Sarah noted, CDA intends to work with 1 or more grantees to administer the Healthier at Home pilot in senior affordable housing sites across 8 pilot counties for 2 years. I think a couple core things I'll call out on this slide. The first is that asterisk. This is the current proposal that CDA is putting forward, and we're inviting folks who've joined today's webinar to provide feedback or ask any questions that might help clarify what this would look like. At a high level, what you can see here is an approach where CDA will award grants to organizations who will then partner with senior affordable housing sites to deliver the Healthier at Home intervention in those housing sites. If we go to the next slide, we can provide a little bit more information there. So who do we mean when we say grantee? So on this slide, we've listed out what an eligible grantee for this program might look like. And so here we've identified that first and foremost, an eligible grantee must be a nonprofit entity operating in California to be eligible for this program. And they must demonstrate the ability to operate across 1 or more pilot sites. So an organization applying for this grant can apply to operate this grant in 1 or more pilots of the 8 different pilot counties. So as a prospective applicant, one would select the counties in which they intend to operate and which they would want to and be able to operate this pilot. A third core requirement for the grantees is they must have care management experience and infrastructure, including operational and clinical management. So these grantees would be organizations that can and have the experience to launch a program like the Healthier at Home program, in which care management is provided with a care management team. The fourth core requirement is having expertise working with an aging low-income population in California. The fifth requirement is to be a HIPAA covered entity and have a HIPAA compliant documentation system that can be used for the pilot. So the grantee themselves would be operating and working with the different sites to ensure that they have HIPAA compliant documentation, they've got the right resources on site and the right training to be able to operate this pilot. And then the last requirement listed here for a grantee is that they would demonstrate interest and ability to identify and partner closely with senior affordable housing sites in each pilot county served by the grantee. And as part of the application and part of the RFA for those organizations, the request for application, organizations will be asked to kind of speak to what that partnership will look like. To give folks a sense of what the types of organizations that might be are, for organizations who meet these requirements, as long as they meet these requirements, an eligible organization may include, but is not limited to, for example, a supportive housing services provider, a care management organization with experience supporting older Californians, or a housing organization that has developed care management capabilities and infrastructure. So this gives you a sense of who that grantee would be that CDA would be working with. And then on the next slide, we'll speak to the partnership between the grantee and the housing sites. Next slide, please. So the eligible housing sites that would participate in this program are really, the criteria for them are listed out here. So in each pilot county, the grantee or grantees will identify and partner with one or more eligible pilot sites where they do not currently operate. And the pilot sites are defined as follows. So pilot sites must meet both of these criteria. The first criteria is that they are buildings that primarily serve older Californians. And that's defined here as buildings that limit occupancy to seniors, defined as individuals over age 55 or a higher age cutoff. And they must meet the eligibility requirement that buildings provide affordable housing to low-income households. And so there's a number of different ways in which a building may meet that criteria. Some of them are listed here. For example, the building might be a HUD-assisted housing multifamily property. It might be a low-income housing tax credit housing site. It might be mixed income housing or public housing. Those are some examples of how a site might meet that affordability criteria, and applicants would be asked to demonstrate how the different sites that they're selecting meet an affordability criteria. Next slide. So what would it look like for a grantee to actually select pilot sites in a county? So in each pilot county, as we've noted, the grantee will work with one or multiple buildings to actually implement the pilot over a 2-year period. In selecting those buildings, the grantee will be asked to look at prospective enrollment in the program across those buildings. The goal in each county is to reach approximately 600 residents across the 2-year period. And this target is informed based on other aging in place programs with similar type of staffing to help us understand what the potential reach of the program might be. Of course, we do acknowledge that enrollment targets may vary by county population and affordable senior housing buildings. So there's an acknowledgement here that in certain counties that are part of this program, the geography between different buildings may be different, and that may impact what the potential reach is, or the number of residents living in any individual building may look significantly different, and that may impact the number of residents that can be reached. So that target, that goal to reach approximately 600, the CDA will account for variation between counties there and take that into consideration and have a back and forth with grantees around that. The grantee may partner with multiple building sites in each county to reach that enrollment target. So CDA does acknowledge that, in many of these counties, there might not be one building site that would have up to 600 people that they might enroll over a 2-year period. And so the grantee would look at multiple different housing sites they could partner with and in the counties where they're working to be able to reach that approximately 600 resident enrollment number where that's possible. Here we've mapped out a potential example of what that might look like for a pilot county. So for example, a pilot county to reach 600 potential enrollments in a county may partner with 3 different housing sites in a given county, one site that has 300 residents, one with 200, one with 100. Of course, given the different sizes of buildings, we would anticipate that the grantee would hire and oversee varying numbers of community health workers and RNs to address the needs of residents in those buildings. The model currently is mapped, the staffing model is mapped to be 1 community health worker for every 100 residents and 1 RN for every 400 residents. So what's listed out here is an approach where, for example, in site A, where up to 300 people may be eligible for the program, the grantee may hire 3 community health workers and 0.75 of an RN for that site to support members at that site. We go to the next slide. So what will the broad responsibilities of the grantee be? We've kind of spoken quite a bit to that first one already, but I'll say it just to say it out loud. Part 1, maybe the first and foremost responsibility will be to hire culturally and linguistically appropriate RNs and community health workers and provide clinical and operational oversight of that staff in partnership with the building sites. So the grantees will be working really closely with the team that already is in these buildings to hire and oversee these healthier at home teams. The next piece here is that the grantee will establish technologies and workflows that are HIPAA compliant and provide HIPAA training to sites as needed to be able to launch the pilot. Once those core pieces are set up, they'll work very closely with the Healthier at Home pilot sites to enroll residents and provide services through the Healthier at Home model. They'll engage the community and connect with existing community resources, again, with very close partnership with the housing sites. And then that last piece there is they'll be collecting data across the course of the 2 years from the pilot sites and supporting the program evaluation. Next slide, please. The CDA does intend to award this grant in 2 phases. So the way that the grant would actually roll out is organizations who are interested in this program would submit an application to CDA. If awarded, the grantee would first receive a planning grant. During that planning grant period, the grantee would be establishing partnerships and memorandums of understanding with pilot sites in order to be able to do the program. So this is kind of that part of the work where each grantee is building the operational agreements and the partnership with the different sites in each county where they're going to operate to get ready for the pilot. There may be other elements of the planning grant, but that is kind of a core element of what the planning grant will entail. Upon approval of the state of having achieved everything that the grantee needs to achieve in the planning grant stage, the grantee would then be awarded an implementation grant, at which point they would have some period of time to hire up all the staff and implement the required workflows in all the sites they've partnered with. And then they would implement the pilot at all of the pilot sites over a 24-month period. Next slide, please. So next, I'm going to speak a little bit to the evaluation element here, and I am seeing some questions pop up in the chat. We're going to be moving to a question and answer section in just a moment, so we'll get to those in just a moment. So in terms of the evaluation for this pilot, a robust evaluation is required by the legislature for the Healthier at Home program, and it will be a key component used to inform long-term design and funding for similar services. So with that in mind, here you can see what the core structure for conducting this evaluation will look like between different organizations and different parties that will be involved in this grant program. So from the pilot sites, pilot sites will be collecting information over the course of the 24-month period that will inform the evaluation. That data will then be transferred to an evaluator hired by the department. The evaluator will conduct the evaluation, and an analysis of aggregate data will be provided to the state based on that evaluation. As a key element in this entire process, the grantee will need to coordinate with pilot sites and the program evaluator to obtain consent from residents to share data, to distribute materials for data collection to residents, and to collect any ongoing program data as needed. So the grantee will have a key role there. The grantee will also need to adhere to approaches for collection of operational data, including participant information and summaries of information from participants as determined in accordance with CDA and with the evaluator. So the grantee will have a key role in supporting the evaluation in this way. Next slide, please. And I believe that brings us to timeline, and I'm going to hand it over to Tanya to speak to this element of the presentation. Tanya?
Thank you, Juliet, and welcome everyone. So I'm just going to speak quickly to the application timeline. So next slide, thank you. CDA expects to release the request for application, the RFA, this fall. The RFA will be posted on Healthier at Home's webpage that we have created. So we provided the link on this slide, and we'll also drop it into the chat right now. But we'll also link it to our CDA homepage to make sure it's accessible to everyone. Interested organizations will have approximately 3 months to apply, but please note that this expected application timeline is subject to change, and you can contact us at any time directly related to Healthier at Homes at the web at healthierathomes@aging.ca.gov, and that has been put in the chat as well. So that's the email that my team will be monitoring. Any questions with regards to this application timeline, and the RFA will be open. So next slide. Okay, so now we're going to open it up to questions and discussions. We would like to provide the opportunity for participants to share perspectives and questions on the proposal for the Healthier at Homes pilot. Thank you. So some of the ideas are we are invited to share any feedback or considerations for the Healthier at Homes model, any feedback on the pilot approach for CDA, any questions about the grantee requirements or responsibilities. So verbal comments, participants may raise their hand, and I will keep track of that. And then the reaction feature of the Zoom, press *9 on their phone on the dial pad to enter the line for verbal comments or questions. I will also look at written comments. I know there was one in the Q&A and as well as in the chat. That's very helpful. And we will make sure everyone can go ahead and start that process at this time. So it looks like the first question that we had, and I'll just have Sarah, if you can respond to it quickly, is will this take place of CBAS?
Great. Thank you so much, Tanya. So the CBAS is the Community-Based Adult Services Program, which provides adult day healthcare services in the community. And the answer is no, this does not replace CBAS. In fact, a resident could be enrolled in a CBAS program and be receiving services through this pilot. I think the key here is that connection between the services provided by the community health worker and the nurse and the other community partners. So ensuring that there is access to the range of services that somebody might need in the community, including but not limited to CBAS and other programs.
Great, thank you. So next question is, how did you reach 400 to 1, the ratio for RNs? That seems exceedingly high for the type of issues you will encounter.
Yeah, great question. And this was based on a lot of the research we did on the other promising programs. So I'll turn it over to you, Juliet, to kind of explain our methodology there.
Yeah, I'm happy to. So as part of developing a preliminary model for this program, we looked at a number of different existing models out there, that specifically those that leveraged RNs and community health workers to understand what existing ratios have looked like for programs. One of the core elements and the key elements in this program is leveraging the community health worker as kind of the consistent on-site support. And that was part of the core part of this proposal, would be that you have a community health worker that is really on-site. Depending on the size of the facility, the idea is largely full-time. And then you have an RN that is coming in to support distinct medical needs and do assessments as needed on residents. So we came to this initial proposal of 400 to 1 based on what some other programs had done, but I think we welcome any feedback or thoughts or reactions to that proposal, and would look forward to that feedback from this group.
Great. Thank you, Juliet. Okay, next question is, can the RN / CHW go into the community neighborhood outside the 4 walls?
Yeah. Thank you, Megan, for elevating that question. This is another was another space where we were kind of thinking through different options. We landed on right now that this pilot would be focused on the residents of these communities for a couple of different reasons. And I'll turn to Juliet to expand upon what I'm going to say, but one of which is for the sake of the evaluation, it might be easier to really have comparative groups across the senior housing site. So that's one. And then the second is we did receive some feedback informally from some of our focus groups that it might be a little beyond the scope to start moving into the community. I love the idea. I just think we need to really focus right now on what we were directed to do by the legislature. But of course, as I said, we're open to other feedback. So Juliet, anything you want to add to that?
No, I think you covered all the key points on that one. Thank you.
Great, thank you. So next question, why is target site where the grantee does not currently operate? Or why?
I can speak to that one.
Yeah.
So part of what's intended when we say that is to indicate that we're looking for organizations to enter into new partnerships and provide new services in a building that does not currently have those services. So we're just making a distinction in that language between potentially a situation where a care management organization is actually already embedded within an affordable housing community, already providing a lot of services. That would not be a site for this pilot program. What we're looking for in this pilot program is entering and providing a new set of services in a building that is not already being served.
Great. And then next question, please share about liability insurance for hiring RNs and CHWs. Can the state provide a blanket policy or other ways to ease the coverage costs?
Well, that is a really interesting question and one that we haven't really explored. So it sounds like there's some potential. I mean, we would love to hear from you if you want to speak to this question, because this is not an area that we had really elevated in our current discussions. Juliet, do you have any other response? Yeah.
No, I again, I agree. I would be actually very interested to hear more information about this question. If the question asker wants to raise their hand to ask it. I think one of the core things that we've been thinking about, and I see they've just raised their hand, but one of the core things that we've been thinking about is leveraging an organization that already does care management and already has an infrastructure for hiring nurses and community health workers to be able to kind of address the structural needs that are needed to be able to do this kind of work. But I see you've raised your hand, so maybe we could have you elaborate.
Yeah, we'd love to hear from you. Yeah.
Great, go ahead and caller. Oh, there you go.
Ayako Utsumi here. Hello, Sarah.
Hi, Ayako.
Hey, thank you for this, all this wonderful information. I think everyone in the stage is very excited. So what I mean by that is, if for example, the housers, for example, like I know the I Wish sites struggled a little bit with the liability coverage with having a nurse on their payroll. That was my understanding. And that it was expensive enough to make it prohibitive. So they wanted someone else to hire the nurses, but that nurse would then be loaned to that houser. So that's my understanding that liability coverage for certified
Got it.
health
Mhm.
providers is prohibitively expensive. Is there a way to somehow share the cost so there's some kind of more blanket opportunity? Right. So again, some of these nonprofit boards may not want to take on that liability. They may have it now, but
Yeah.
maybe they want to, they may not want to no longer have that liability. Are there some options?
Yeah, I'm happy to take this one.
Yeah, go
I
ahead.
think this really gets to the core of this pilot structure, which is instead of asking nonprofit housing organizations that do not have an infrastructure for taking on, as you said, the liability, the HIPAA compliant training, the platforms that are needed to be able to do this kind of work on site. The proposal is actually to hire a care management organization as the grantee. The grantee, that care management organization, will be the organization, and I'm using the term care management organization quite broadly in the statement, just to say, but that care management organization would be the organization that hires the nurses. And so the nurses would actually be on the care management organization's payroll, and would have clinical oversight from the care management organization. So that is intended to eliminate the exact kind of challenge and friction you're speaking to, Ayako, there.
Okay. So just to follow on to that, if I may, then, so for example, the SASH model is really set up such that the property management staff, the housers are more integrated with the healthcare team so that everyone is on the same page. But if the care organization, services organization is separate from the houser property management, then we lose some of that collaborative,
Yeah.
the facilitation of that if they are separate organizations. So that's just the thought too.
I appreciate that, Ayako, and I think that that's why that planning phase is going to be so important, because we want to make sure that there is not, that there's close collaboration and that the care management, broadly speaking, care management organization and the housing organization are approaching it with protocols and information sharing to ensure that they're all on the same page and moving forward together in the effort, and that it's not kind of an outside entity coming in without the coordination of and input from the housing organization.
Great, thank you. Appreciate that.
Absolutely.
All right, great. Well, I'm going to read a question from Patty. Will it be possible to reach the 600 resident target population over 2 years in the rural communities? And I know, Sarah, you responded to that.
Yeah, no, it's an important point. I think that's why, Julia really wanted to have a qualifier that, yes, we would love to see 600 per county. That's a number that we have, is our kind of target goal, but we are also going to be taking into consideration, the different demographics of the counties. And it might be that, as we get into the discussions with the grantees or grantee, that we have to revise those numbers by counties based on that.
Great. Next question is, what is the financial value of the project to grantee organizations?
So yes, thank you for that. It's almost like, well, what's the benefit, right? I would say that, the benefit for residents is clear. It's, helping them access the services and supports they need, reducing caregiver burden, and helping connect them with what they need to remain in the community. For the actual housing site, the benefit is that their residents are going to be getting good services and more likely to access what they need to avoid having any disruptions in their housing. So it's not necessarily that it's going to be a generator of income for new source of income, financing for the housing organization, but it will help them in the sense that they will be able to provide good services and connections to the services and supports that the residents might need. So I'm not sure if that exactly answers the question, but of course, we do want to have the model be financially viable for the applicants. So whatever the grantee organizations or the care management organizations are that apply for it, we believe that the resources that they will be getting will definitely cover the costs of what they need for conducting the pilot.
Okay, next question is, are these existing structures or new buildings?
So I think if I'm understanding the question, the way that it's being presented is that we are going to have agreements between the care management entities and the housing organizations that are existing structures right now in each of the 8 counties. So we're not proposing to build new housing or to develop new senior housing. That'd be great if we had resources to do that. I don't think CDA would be the one to do it, but so I don't know if that was your question, or Juliet, did you want to add on to that?
I think that's what I understood the question
Yeah.
to mean as well. So agree with you there.
Okay.
Mhm. Okay, I'm going to go over to the Q&A section. And the question from Ryan is, what is the methodology for grantee funding allocations?
I think that will be something that we develop with the grantee through the contract and budgeting process. We don't have the real specifics outlined now. Juliet, did you want to talk about what we anticipated the general cost to be, or the general amount that could be awarded for
Yeah.
the administration?
Yeah, so the total for the entire program is 12.5
Right.
million. I think we're still kind of working out exactly how that's going to get divided into different types of costs associated with the program. So can't share exact details about what the total amount for the grant will be just yet. But I do see part of your question, Ryan, is about kind of if you have a grantee that's serving, if you have multiple grantees, how would the allocation be distributed? And certainly to your question, to the point you made in your question, the number of counties that are being covered and the different costs for operating in each county would be considered as part of the allocation.
Great. Another question is, are you offering technology consultation, software standards, and templates for grantees? Many housers may not be familiar with health-related data collection.
Ayako, you anticipated many of the questions we were having as we were developing this concept, which is why we want to have a grantee that has those capacities already and then can work with the different housing organizations. We do not anticipate that the housing organizations would be transferring health-related data. It would be the grantee. So Juliet, anything to expand on for that?
No, I think that's exactly right.
I'm going to go over to the webinar chat. It says, from Pamela, I'm curious how the RN and CHW will collaborate with HUD assisted senior communities who have a service coordinator on site.
Mm-hmm.
Yep. Wonderful question. And I think that, again, we will turn to our grantees and the proposals they come up with their housing organizations. I think the most important thing is communication and collaboration. It doesn't mean that they'll be discouraged from working with the resident services coordinator. We will want to make sure that they supplement and complement what services the resident services coordinator are providing. So it'll have to be a very kind of seamless and an approach that they both know what each other is doing so that there's not confusion and duplication.
Next question in the chat is from Selma. Is the RN role a seasoned clinician for assessment, or specifically a NP who is a healthcare provider?
Yeah. Great question. And absolutely, this is an RN that's primarily doing assessments and identification of needs. This is not to take place of the existing medical care that the individual should be getting from their health plan or from their provider in the community. That is very important so that we're not duplicating it might be that the nurse there's some emergent need that they have to address, but that in general, this is not a clinician. It's more of a assessment and not providing in-depth medical care services.
And I think, Sarah, that also answers Corinne's question. I'll just make sure to read that real quick. Are the nurses doing real nursing? In MSSP, we get around the most expensive coverage because we did not allow nurses to really nurse. They
Right.
issue no meds, treat no wounds, etc.
Exactly, Corinne, you got it. The intention is, especially given that it's a core, the ratios for the nurse are not enough to provide that direct care. They're more there to provide the assessment and the needs identification and to help then work with the community health worker to line them up with the services they need. They likely would, if there's a medical care need, then reach out to the medical care team and the health plan, if they're in one, to make sure that that need is getting addressed.
Great. There are a couple comments I'm just going to read quickly because they're helpful. Pamela provided a comment on, we are a pilot site for HUD's I Wish program, and based on that experience, the 600 to 1 RN is very high. So, and then from Patty providing in the chat a second interim evaluation report on the federal HUD I Wish program for folks to reference. Thank you, Patty, for that. And then I will go ahead and go to the next question in the
I just want to clarify one thing. It's not 600 to 1 for the nurses. It's 400 to 1 for the nurses and 100 to 1 for the CHWs. It's the goal to get 600 residents enrolled. So we appreciate that input and we'll definitely take that into consideration if you want to follow up with your experience with IWISH and what the ratios are that you have used in your program with nurses.
Great. Okay, so from the Q&A from Catherine, can you elaborate on the type, range of community services and supports that the program will seek to connect residents with? Also, what will those connections look like? Example, how formal MOUs will be created? Will community programs be vetted for capacity, quality, accessibility?
Wonderful question. And I would say that a couple things. One is in terms of the range of programs and services, I think we're open to, depending on the resident's needs. So it could be that the resident says, I need something to do and I kind of am getting isolated in my home. So I really want to engage more in the community. So the community health worker could help find some volunteer opportunities, for example. Okay, that could be one thing. Or it could be that this person really has a high level of need and gee, they're enrolled in CalAIM and gee, wouldn't they be great for enhanced care management? I'm going to follow up with their care coordinator at the health plan and see if they can access enhanced care management. Or it could be that they need some sort of modification done, like a grab bar put into their home so that they can follow up with the housing entity and see if, what resources might be available, et cetera, et cetera. I think that the planning phase of this will be really critical because that's when we're going to want to see the organizations that they have partnered with in the community to form these kind of arrangements and who the organizations are and what their kind of the background check, if you will, for the different organizations. We want to make sure that, of course, that these are entities that are vetted in the community. So Juliet, anything to add on that?
I think the piece I'd add is there's a tremendous opportunity through this pilot to have a very hyper-local approach to these resources because you're going to have community health workers who are on site in these buildings more or less full time, and then nurses coming, every week to the building. And there's an opportunity to be able to understand the resources as Sarah was speaking to at the state level, at the county level, at the city level, and then even down the street that you might not have with like a massive, a less local focused pilot.
And we have Patty's hand is raised. So Patty, if you want to take yourself off mute.
Thank you. Yeah, thank you. So I know one of the issues that came up in the IWISH program and one that California is facing, kind of throughout the state is that of workforce shortages and particularly in the healthcare area. And the IWISH program found that it was very hard to keep the positions filled, and that there was a lot of transition as new people were hired and had to be brought up to speed. And I'm just curious, because CDA and Department of Healthcare Services is doing a lot around workforce development and retention and compensation and training, if there's any way to bring those efforts together to sort of ensure a more positive launch of this program, which is a fabulous program, but really depends upon people on the ground being ready and able to step into these positions.
Yes, thank you, Patty. It's such an important point about the workforce and how difficult it is to hire nurses. We hear it all the time from our programs. That is why, a couple of things, we are going to work with the community partners or the grantees that might already have an existing infrastructure. And we welcome opportunities, of course, to leverage some of the existing workforce training programs that the state is having. And we would welcome any suggestions that you all have. We recognize that this really is one of the most critical needs of the program and one of the difficult challenges, but we also believe that with some creative approaches, we can, identify the nurses that might already be out there or be connected with an organization already. Juliet, anything to add to that?
No, I think that captures it well.
I'm going to go to the webinar chat where Barry provided a question on, in general, are there a lot of low income senior living apartments in California? And then the second part of his question is, seems such living arrangements are the foundation of this model. Is that correct?
Yes. So our partners at Manat did a lot of kind of research on this and looking at the different housing model types. And Juliet, do you want to expand on what we learned?
Yeah, so there are a wide range of different types of low-income housing buildings for seniors in California. And part of what we've endeavored to do in this pilot design is leave an opening for different types of affordable housing communities. So understanding that the landscape may look a little different in each of the different counties that this pilot will operate in, we've left a pretty wide range of options in terms of the types of buildings that could be partnered with. But to your kind of point about the fundamental of the program being focused in these buildings, yes, I think a big element of this program is understanding the opportunity to be able to provide resources in these buildings in which individuals who are aging and may be at risk of having to go to a skilled nursing facility if they have a decline. A big part of this program is understanding whether we can support individuals in aging in place by providing more resources in this, group way by having it in the building and available to everyone that lives in the building.
And thank you, Sarah, for including in the chat some funding sources for qualifying affordable housing sites. So I'm going to go to the Q&A section. We have a question on, are there standards for measuring baseline target resident health and wellness?
So this is not something that we've set yet, but there is certainly a concept in the pilot. I think we spoke to it a few slides back, that there will be assessments of residents and that different types of assessments will be leveraged throughout the program to understand a resident's current state of risk for aging in place, and then to check in and see how they're doing. So I think that would be an element that would inform the understanding of baseline health and wellness of a resident. Would you add anything to that, Sarah?
No, I think that's right. I think that these are the kind of discussions we're going to be having with the grantee too, to determine the specifics. But we don't want to define that this early on, knowing that our grantees might have some good input on what tools we use.
Thank you. Okay, next question is from John. Did AB 2548 specifically spell out participating counties? Will there be an opportunity for expanding participating counties in the future?
Good question, John. The answer is yes. AB 2548 did specify these counties. This was not something the department had the flexibility. So, you know, right now it's a pilot. So based on the evaluation and, you know, what the kind of business model is and where there is financial opportunity for expansion, you know, the next phase is kind of up for consideration based on what happens with the rollout of the pilot. But at the end of it, then at that point, the legislature could consider whether they want to include additional resources to expand it to other counties.
Yeah, thank you. Next question is from Sade. Is this only open to nurses? Will this grant accept other care professionals that don't have a nursing license?
Yeah, hi, Sade, thank you for that. Yes, as specified by the legislature, in what was agreed to as part of the budget agreement, it does require an RN and a community health worker, for the site. So we do not have flexibility in that.
Thank you. And I know we have 5 minutes left. We have 2 more questions I think we can answer. So in the Q&A, there's another question. It may take 6 or 9 months to enroll because older adults may take time to trust. The intervention period could then be just over a year and 1/4. 1/4. Is that an adequate term to test the pilot and conclusive changes in health status?
Yeah, I think that, you know, again, I don't anticipate that at the launch of the program, everybody's going to enroll within 1 week. I think it'll be a rolling phased in process, and some might drop out and some might then re-enroll, but that the actual term of the pilot, not including the planning phase, will be a 24-month period. So, so that doesn't mean that every enrollee is going to necessarily be in for the entire duration. I think it just depends. Juliet, anything to add to that?
Yeah, I mean, I think we acknowledge it takes a minute to ramp up a pilot. I think one element that we're hoping to be able to leverage for this pilot is that partnership with the building team. This is not someone coming in completely unknown to the building. They're coming in and building a partnership with the building team, getting the intros from the building team. You know, someone earlier spoke to the service coordinator in HUD buildings. That individual might be able to be a really good source of warm handoffs. So that element of integration is, I think, really key to being able to support a quicker ramp up period for the pilots.
Great. And last question is, will funds be available within the project to help residents pay for services they may need but can't afford, such as adult day programs?
That's a great question. Unfortunately, you know, the resources we've been provided are for the administration of the program to support the nurse and the case manager at the different, or sorry, the community health worker at the different sites, and for the evaluation. So no, but I think that that's where there are certain funds out there, like the community living fund that's being administered by the Department of Rehabilitation. So in the case of this individual, if they need, say, a you know, home modification and they can't afford it, that is a wonderful new fund that's been launched where hopefully the community health worker would work with a local service provider and help that individual get the resources that they need, as an example.
Okay, and with that, that concludes our Q&A section.
Right. Well, I will just say thank you. This was super informative in terms of hearing your questions and your comments. And I just want to underscore, please send us your comments and feedback in writing. If you feel really strongly about these different issues that have been identified, beyond what's been specified in statute already, we do have, you know, some parameters and how we can design this. So we really appreciate your input, and just be on the lookout for next steps when we release the RFA. Juliet or Tanya, anything else?
No, thank you so much, everyone.
Yes, thank you, everyone.
Just reading the chat.